eating disorders. My name is Miyosha. I'm currently a second year MPAS student, which is a Master of Physician Assistant Studies at the University of Manitoba. So I'm in my second year, hence the PAS2 here. And you can contact me for any details about my presentation or anything to do with PA school if you're interested at the short and sweet PA. So I'm just going to start right away. So I would like to start with this slide here, acknowledging the land that we're all in today. The University of Manitoba campuses are located on original lands of Anishinaabe, Cree, Ojibwe, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. This was taken from the University of Manitoba website. So before I start, I thought I'd put a disclaimer on here. Eating disorders is a very sensitive topic. So there's going to be a lot of information here, which some of you may find it hard. So at any point of the lecture, please feel free to take a break. You're very welcome to do so. And there's also some crisis lines here that I've noted down. And I will be talking more about resources and where to go for help at the end of my lecture. I'll just give a couple minutes here if anyone wants to write them down. All right, so the objectives of my lecture. By the end of this session, you will be able to distinguish between different eating disorders, know the trends and patterns of diagnosing eating disorders, know what research is required on eating disorders in the future, and know where to go for resources on eating disorders. So to start with, there is this article that kind of captured my eye. It's titled "Number of Americans Requiring Inpatient Care for Eating Disorders Doubled During the COVID Pandemic, Study Finds." So this was taken from Daily Mail, UK. And so if you can see the graph here, these are the admissions on the y-axis, and then you have on the x-axis the years 2018, 2019, and 2020 when the pandemic started. So you can see there how big of a rise there is here between, for example, 2018 and 2020, even 2019 and 2020. You can see all eating disorders have had a major increase, and that's very disheartening. COVID did affect many illnesses and patients overall, but this is really disheartening to see how it has doubled the rates for eating disorders. And the next article here is from CNN. It says eating disorders have risen in recent years. A new finding may help catch them earlier. So the results from this study that this article was talking about, it showed that people who experience electrolyte abnormalities were twice as likely as those who didn't to be diagnosed with an eating disorder, sometimes more than a year later. And people with severe abnormalities were more than 5 times as likely to be diagnosed. And I'm going to show you a graph now of the results of the journal article that the CNN article cited. So as you can see here, people with an eating disorder, the darker bar graphs here. So if you can see here, it's substantially higher than people without an eating disorder, which is the lighter bar, and hypokalemia, which is an electrolyte imbalance with potassium, so low potassium, and then you have hyperkalemia, which is high potassium, and then hyponatremia, sodium, hypernatremia, sodium, and then hypomagnesemia from magnesium, and phosphatemia for phosphate, and metabolic acidosis when your fluid levels in your body are more acidotic, and alkalosis when it's more alkaline. So as you can see, people with an eating disorder, the percentages in those individuals are way higher. So I'd like to start a Mentimeter here. If you can all let me know why learning about an eating disorder is important to you. Again, these are anonymous, so I wouldn't know who's answering what. So I'm just going to start it. So if you can go to Mentimeter here and enter this code, you should be able to write down the answers for me. I'll give a couple of minutes here. Give it one more minute. Perfect. So to help others, I had one to build awareness. Some common themes are to understand what they are, to reduce the stigma. These are wonderful, wonderful reasons to learn about eating disorders. And this is why I picked this topic, because I feel like not a lot is spoken about this topic, although we see it every single day on social media and everywhere else. I don't think it's spoken a lot about. So yeah, thank you very much for everyone, to everyone who answered. I really appreciate that. To help others, to help loved ones, of course. And there will be some resources at the end so that everyone will, know where to go if you need to help someone or to help yourself. And I will also send these slides after the lecture. So we're going to start talking about different kinds, and the ones which are like bolded are the ones which are very common. And pica and ARFID are less common, but they are, of course, around. So we have bulimia nervosa, anorexia nervosa, binge eating disorder, other specified feeding and eating disorders, pica, avoidant restrictive food intake disorder. So let's start with the epidemiology. Specifically, I wanted to kind of focus on Canada because we are in Canada. So it's important to know what is going on around us. So about 1 million Canadians would meet the diagnostic criteria for an eating disorder. Eating disorders have the highest death rate of any mental illness. 1 in 10 people with eating disorders die from their disorder. This was a quite shocking finding for myself. I'm sure some of you in the audience would think the same. Canadian doctors, including those in training, feel unprepared to treat patients with eating disorders. As a future physician assistant going into the medical field, as a medical professional myself, this was something that touched my heart as well. More than 1 in 5 Canadian teenagers are on a diet at any one point, putting them at risk for eating disorders, which again is a shocking statistic. So if, usually if someone has an eating disorder, the first kind of point of contact would be a primary care provider. So as a primary care provider, sharedcare.ca has come up with this PDF. This is a table from that PDF in terms of letting primary care providers know what their role would be in terms of helping patients who have eating disorders. So I'm not going to, go through every single box here. Again, you will get these slides after, so you will have them with you. And there's also references at the end that you can follow and look at the PDF yourself if you're interested. So our role, if you're going into primary care medicine, is early identification to know who's at risk and who to follow and how to help them. Then the medical management, medical monitoring, treatment, and advocacy. Patient advocacy is a huge thing for this population, this group of patients. And it's very important that you understand what they're going through and help them break the stigma around it. So we're going to start with bulimia nervosa. This is food restriction followed by binge eating with periods of purging. So some of the signs and symptoms are weight change, dehydration, purging behaviors, concern with body weight, food intake restriction, toothache, discolored teeth, swollen cheeks or jaw. So according to the DSM, recurring episodes of food restriction followed by binge eating is something that we need to keep an eye on. Recurring behaviors that follow binging in order to compensate for the food intake and preventing weight gain. Person tends to negatively evaluate their weight and shape and feels these matter more than most any other features on them. The restricting, binging, and purging cycle occurs at least once a week for 3 months. And then we have anorexia nervosa, behaviors that interfere with maintaining an adequate weight. Some of the signs and symptoms are extreme weight loss, anemia, feeling cold all the time, abdominal and GI issues, preoccupation with food. So they constantly think about, what am I going to eat or what am I not going to eat, like counting calories and things like that. Insomnia is a big thing, irritability, dresses in layers of clothing to hide body. This is something that you will see amongst many other eating disorders as well. And they deny hunger. And another thing is that they use laxatives. They overuse laxatives. There's a myth out there that using laxatives will make you kind of, not absorb the food that you eat. So patients with anorexia nervosa or individuals with anorexia nervosa would take laxatives right after they eat most of the time, thinking that, this will go right out of their bodies. They'll excrete it out and it won't be in their body. It won't remain in their body, which is a huge misconception. So according to the DSM, persistent behaviors that interfere with maintaining an adequate weight for health, powerful fear of gaining weight or becoming fat, disturbance in how the person experiences their weight and shape, person does not fully appreciate the seriousness of their condition. Then you have binge eating disorder or BED. These are recurring episodes of binge eating and feeling out of control of much is eaten, eating a large amount of food in a short period of time. And some of the signs and symptoms are changes in body weight, hoarding food, guilt and anxiety surrounding food, and again, dressing in weather inappropriate clothing to hide the body. So the DSM says binge eating episode also includes 3 or more of the following: eating very quickly, eating regardless of hunger cues, even if one is already full, eating until uncomfortably or painfully full, eating alone due to embarrassment about the type and quality of food ingested, feelings of self-disgust, guilt, and depression. Binge eating episodes are not followed by compensating behaviors such as excessive exercise. So anorexia nervosa, individuals who have anorexia nervosa can show like vigorous amounts of exercise every, few hours, every few hours a day. Self-induced vomiting. such as bulimia nervosa, or the misuse of laxatives or diuretics, again, as anorexia nervosa. Binge eating is seen as a disorder when the binging episodes occur at least once a week for 3 months or more. Again, 3 months is what the DSM says. So it's, I'm not sure if everyone is aware of what the DSM is. My apologies, I should have explained what that is before, but the DSM is the diagnostic manual for psychological disorders and illnesses. Everything has a specific list of signs and symptoms that you use to kind of help sort out what the diagnosis is that someone's having. So other specified feeding and eating disorders, or OSFED, the DSM-5, which is the recent version, a person must present with feeding or eating behaviors that clinically are significant. They distress them and cause impairment, but they don't meet the full criteria. For example, for atypical anorexia nervosa, all criteria for anorexia nervosa are met, except despite significant weight loss, the individual's weight is within or above the normal range. So the weight is within the normal range or above the normal range if it's atypical anorexia, whereas typical anorexia, you have severe weight loss. And the next is binge eating. All of the criteria of binge eating are met, except at a lower frequency or limited duration. So it'll be less than 3 months, according to what the criteria is. And then for bulimia nervosa, all of the criteria are met, except the binge eating and inappropriate compensatory behavior occurs again at a lower frequency or at a limited duration, again, less than 3 months. It doesn't have to be 3 months to be certain that it's bulimia nervosa. It can be an OSFED. And the purging disorder is another one, recurrent purging behavior to influence weight or shape in the absence of binge eating. And then the last one is night eating syndrome, which is recurrent episodes of night eating. So, you eat after you wake up from sleep in the middle of the night, or you consume excessive food after an evening meal. So you eat your dinner and then you have more food after. The behavior is not better explained by environmental influences or social norms. Behavior causes significant distress and impairment. Behavior is not better explained by any other eating disorder. So then you have pica. So pica is an eating disorder that involves eating items that are not typically food. They do not contain any nutritional value. So this can be hair, dirt, paint chips. And interestingly, in my rotation, I just finished trauma surgery rotation here. And my rotation, I had a patient who presented with pica, and that was my first time seeing a real life, individual going through pica. And she ate drywall. She was extremely malnourished, and there was nothing. They were extremely poor, and they didn't have anything to eat at home. So she kind of turned into eating drywall at home. So there were walls in our house that she's eaten through. And it was a severe case. So we, as the slide says, iron deficiency, anemia, and malnutrition are two of the most common causes of pica, followed by pregnancy. There's not a lot of clarity within how the connections are made between the brain and, this electrolyte imbalance or the nutrition deficiency. But what happened to this in the case that I saw is that her iron was almost zero. There was no iron in her. So that was a great example that, is like typical presentation for pica. So pica is a sign that the body is trying to correct a significant nutrient deficiency. Treating this deficiency with medication or vitamins often resolves the problem. So we gave her IV iron right away. We knew what was going on, and that seemed to help a lot. Of course, she was in the hospital, and she, didn't tend to try to eat anything that she was, not supposed to, but it brought her iron levels back right up. And of course, there was food that she consumed, and she was feeling much better when she left. It often occurs with other mental health disorders associated with impaired functioning. So, for example, they may have intellectual disabilities or autism spectrum disorder or schizophrenia. First-line treatment for PICA is, again, as I said, you need to help with bringing their nutritional values up and their mineral values up. You need to correct them. So the next is avoidant or restrictive food intake disorder, or RFID. This involves limitations in the amount or types of food consumed, but unlike anorexia, RFID does not involve any distress about body shape or size or fears of fatness. So in this, disorder, you see significant weight loss, significant nutritional deficiency, leading to suboptimal development, dependence on nutritional supplements. So they might consume lots of supplements in order to, maintain their health. Marked interference with psychosocial and potentially physical functioning. Then you have rumination disorder. So this is consistent regurgitation of chewed and or partially digested food over a period of at least a month. Previously swallowed food is brought up into the mouth effortlessly with no sign of gagging or nausea. So they get so used to doing this that, it almost becomes autonomous or automatic. It just happens right after a meal. The body gets habituated, or the brain gets habituated. So some of the symptoms you can see on this infographic here: bad breath, constipation, nausea, diarrhea, bloating, tooth decay because of the acids coming up into your mouth and, rotting the teeth, weight loss, stomach aches, dry mouth or lips is another symptom for rumination. Now I have a short video here, just a quick kind of summary to put all the eating disorders together.
In a month.
Oh, I'm so sorry. I just got some chats that can't hear anything. My apologies. Okay, let me try this again.
My son was on the wrestling team. When he cut weight by 2 classes, we started to worry.
We had always enjoyed family dinner together, but my daughter started to be very rigid about what she would eat. Eventually, she refused to join us and stayed in her room.
One of my boys would just sit and watch TV and eat snacks. I would find wrappers and food containers everywhere, and he gained 20 pounds in a month.
Our oldest daughter would leave the table to be by herself after every meal. She got sick all the time and looked so pale, but she wouldn't talk about what was going on.
These are the voices of parents who have noticed behavior in their children that could indicate a feeding or eating disorder. The most common of these disorders include anorexia nervosa, bulimia nervosa, and binge eating disorder. These are complex mental health conditions that often occur during the teenage years and can be the source of physical problems, emotional distress, and even medical crisis. Detecting feeding and eating disorders as early as possible is an important step in helping. Keep a few simple things in mind. Watch behavior. People with feeding or eating disorders often attempt to hide their conditions. Watch for behavior like withdrawing from family mealtime, refusing to eat certain foods, having a rigid rule about food, stockpiling or hiding food, calorie counting, excessive exercise, vomiting when not ill, or using laxatives. Try to connect. Talking about these challenges must be done empathetically, compassionately, and kindly. but the seriousness of the conversation must also be clear. People struggling with their thoughts about food and weight often feel alone, misunderstood, and hopeless. Unwavering support and personal connection from family is vital. Expect resistance. A person with a feeding or eating disorder can experience deep embarrassment, shame, guilt, fear, and hopelessness. It is important for family members to be as patient as possible. It often takes time and repeated efforts in order to successfully discuss concerns. Physical health can deteriorate. When feeding or eating disorders remain untreated and symptoms persist, family members may see dramatic changes in health, including sudden weight loss or weight gain, high or low blood sugar, easy or frequent bruising, unhealthy skin and hair, easily broken bones, gastrointestinal problems, rotting teeth, and other significant medical issues. Crisis is possible. Physical deterioration can lead to crisis. While most people receive care prior to a crisis, advanced feeding or eating disorders can result in life-threatening situations, including cardiac arrest, coma, organ failure, and suicidal thoughts and behavior. If this happens, emergency medical attention should be sought immediately. Treatment works. Feeding and eating disorders are serious conditions that are scary for the person suffering and the family. It's important for family members to confidently discuss the treatment options for these conditions and know that evidence-based treatments can be successful. Because these disorders are common, there are mental health providers, physicians, crisis lines, peer support groups, and organizations dedicated to providing useful, empathetic, and supportive resources for both patients and their families. People experience feeding or eating disorders together with their families. The conditions can be scary and they are dangerous if left untreated. But families and people can seek treatment together, and treatment works. With some basic preparation and awareness, a family can find and provide help. And with this help, there is hope. If you or someone you are worried about is struggling.
Sorry about the video sound in the beginning. So some of the treatment options we're going to dive right into. So types of therapy, we have cognitive behavioral therapy, or CBT. It's based on the assumption that thoughts, emotions, and behaviors are interconnected and can be restructured to support new, healthier thoughts and actions. So it's talk therapy. So you talk, someone a professional who's qualified, and it's based on emotions and thought processes and changing the way we look at something or look at ourselves. Then you have DBT, which is dialectical behavior therapy. It's based on the assumption that self-destructive behaviors are caused by the inability to manage and regulate intense emotions. It combines CBT with mindfulness and acceptance strategies. Usually DBT is done in combination with CBT, as I just mentioned, and they go hand in hand. Then you have emotion-focused therapy. Individuals learn how to manage their maladaptive emotions, as opposed to controlling what they eat as an outlet for their emotions. So this is a very, very well-used treatment option. That it's a popular one. And family-based treatment is another good one, or the Maudsley model. Parents of children and younger teens are empowered to take responsibility for managing their child's eating disorder symptoms with the goal of restoring their child's health. I think it's very important to involve the family because, one, you're educating the family as well in terms of how to kind of support their child or, loved one. And that's important that they know because they are with the family member more than, the professional is. So it's important to get them involved. And another reason is that it might be stemming from their families, certain, different cultures look at weight in different aspects. I am half Chinese and half Sri Lankan. And, the way that I was brought up, weight was seen in a very different lens when compared to the Western part of the world. So it's very important to educate, again, the family members to make sure that they know how to support their child or their loved one. And then you have emotion-focused family therapy. Coaching is integrated into the Maudsley model, as we discussed before. A parent or caregiver helps their child to identify the process emotions that come up in the process of eating disorder, recovery, allowing the young person to feel compassion and understanding of their parent. So while the parent's trying to take care of the loved one, they will in turn understand what they're going through, the parent is going through as well. Parent also learns to recognize their own actions are being controlled by maladaptive emotions. So, if the parent is someone who has encouraged, the child or the loved one to focus on their weight and to, keep asking them to lose weight for whatever reason, then this is a good kind of treatment plan for them as well. And then the last one is the peer support group. Support groups are always very, very helpful for any disorder or any mental illness. And group members are going through similar struggles. So they come together and they talk about what they're going through, and they kind of bounce ideas off of each other, because something that works for me might also work for the next person. Then when we talk about pharmacotherapy and other treatments, so one thing is nutritional rehabilitation. I need to be very careful about refeeding syndrome though. So refeeding syndrome is when when someone's not eating for a long time and then you feed them too fast, at a high-paced at a high rate, and then that would affect the electrolytes in their body, and it will cause an imbalance, and it can lead to cardiac issues or respiratory issues and things like that. So you have to be very careful. It has to be very gradual when you start the nutritional rehabilitation. And then you have SSRIs and antidepressants, so sertraline or Zoloft is a very common thing that everyone uses, or Paxil. And then olanzapine. So this is not first line, but it's very, very helpful with helping patients who are, very underweight to gain weight. Plus, it also helps with distorted thoughts and that one might have with their body image. So olanzapine is a very effective drug that we can kind of use. And then you have deep brain stimulation. So this is actually in experimental stages. And I have a quick video here for those who do not know what DBS is. I thought it would be important to talk about it because it's very, very, it's a very interesting topic here.
Deep brain stimulation is a neurosurgical approach that involves the use of brain-implanted electrodes to treat a variety of neurological and psychiatric conditions. It is primarily used to treat movement disorders like Parkinson's disease, but has also been approved by the FDA for use in treating epilepsy and obsessive-compulsive disorder, and is being studied as a potential treatment for a number of other disorders like chronic pain and depression. Deep brain stimulation involves the insertion of an electrode into the brain. The electrode is connected to a wire that runs under the skin to a device called a pulse generator, which is usually implanted under the collarbone. When the pulse generator is turned on, it emits electrical impulses that alter neural functioning. In Parkinson's disease, for example, the electrode is typically placed near structures like the subthalamic nucleus, whose overactivity in the disease is thought to contribute to movement problems like difficulty initiating movement. Modifying the activity of these overly excitable regions can alleviate the symptoms of Parkinson's disease. It should be noted, however, that deep brain stimulation is major brain surgery, and thus there are risks associated with the procedure. Despite numerous studies that have investigated the mechanism of deep brain stimulation, there is still a lack of clarity as to how the treatment leads to beneficial effects. Several hypotheses have been proposed to explain the mechanism, and they are not necessarily mutually exclusive. For example, deep brain stimulation may inhibit action potentials by causing prolonged depolarization of neuronal membranes, reduce neuronal activity by prompting the release of inhibitory neurotransmitters like GABA, and disrupt abnormal rhythmic neuronal firing that might interfere with healthy brain function. But more research needs to be done to develop a clear understanding of the effects of this treatment on the brain.
You can type to the chat too if you want. All right, if there's not any more questions, thank you so much for having me. Again, if you want to connect with me to talk more about, research, I was a research assistant for 4 years before I joined PA school, or where to go look for, leads or connections and things like that, networking. Reach out to me at the Short and Sweet PA is my Instagram. And if you want to know more about PA school as well, don't hesitate to reach out to me.